we all know we're going to be speaking about Ebola today. Our speaker is Dr. Phil Fisher. Dr. Fisher is a great advocate and friend of Samaritans Purse. He and his wife Julie have served for many years on the mission field in the Democratic Republic of Congo as medical missionaries. Currently, Dr. Fisher works in pediatric and adolescent medicine at the Mayo Clinic in Rochester. Historically, Dr. Fisher, with regard to his undergraduate and doctorate studies, he studied at the University of California, Irvine. He completed his residency at the University of Utah. In addition, he has completed the Tropical Medicine and Hygiene course through Liverpool School of Tropical Medicine. Dr. Fisher is a very gifted speaker and is an expert in infectious disease. So we're delighted for you, Phil, to be here with us today. And with that, I will turn it over to you.
Thanks very much, Lance, and greetings to all of you.
Dr. Fisher?
Ebola. Oh, yeah, can you hear me? Are you hearing me now,
yes,
Lance?
Sir.
All right.
I hear you very well.
Thank you very much, Lance. And I hear you. Thank you. And greetings to all of you scattered places as we're joining together. Certainly the term Ebola, the thought of Ebola, and the wonderings about Ebola trigger lots of emotions and reactions for all of us. For some of us, it gives fear. It's been in the news lately, and people are afraid of what's happening. Others still sense a feeling of adventure and wanting to jump into the action. And for many of us, it promotes us an idea of sadness and sorrow as we think of particular people and individuals and groups of people we know that have been affected by the current outbreak of Ebola and that have suffered and even died because of it. During this session today, we'll tell a few stories, we'll provide a few answers, and we'll discuss involvement and what we can do. And hopefully this will help us all to be able to be a little bit more familiar with the diagnosis, management, and prevention of Ebola. And it might also give us some ideas how we can all fit in and how God might want to use each of us as He continues to work in scattered places around the world. But I have to begin with a disclaimer. I have never cared for a patient with Ebola. When we worked in Congo, I used to hope to be able to see a case because I thought it would be pretty cool. I'm not sure that's a good reason to want to see a case. And several months ago this year, Lance offered me the opportunity to go to Liberia, but schedule-wise it didn't work out. But I will admit that I am not an expert on Ebola from any personal experience, and I realize that some of you joining with this conference today have seen hundreds and hundreds of patients with Ebola and know a lot more. So I'm looking forward to some interaction and seeing what we can all learn from each other together as we talk about this. And as we go on, is everybody hearing me okay? Speak up or make noise or send in a little note if anybody's having trouble with audio.
No, on this side, we hear you very, very well, Dr. Fisher.
All right. Thank you, then. So we can continue along. I do give credit for some of the slides we're going to show and a lot of inspiration in my life to Lance, pictured standing here next to, reportedly, the first survivor in Liberia of the current outbreak of Ebola. And I think Lance and Harrison each have lessons they can teach all of us. So what is Ebola, and is it a big deal? I've had lots of people in recent months asking me about Ebola because they think I'm aware of things in other parts of the world. And one of the questions just is, what is Ebola, and is it a big deal? And that's a reasonable question. Now, if we follow news media, we know it's a big deal. Some involved here have been personally involved with Ebola. But what's going on and where is it? Africa's a big place, but there are lots of places with Ebola now that are currently affected. And if we focus in on the western part of Africa, we can see a map that's now a little over a week outdated, but showing the main parts of this outbreak with Guinea kind of curving around in Africa, Sierra Leone in the middle area, and then Liberia, where lots of you have experience down here towards the bottom of the map. This is a World Health Organization map with the red dots bigger if there have been cases within the 3 weeks prior to a week ago. The dots are bigger and more numerous on this week's that came out after we made these slides, as there's been an explosion of Ebola cases, especially in Liberia, with more areas affected and with more people affected. So when we're talking about the current outbreak of Ebola, we're mostly talking about Liberia, Sierra Leone, and Guinea. As we consider what's going on, we realize that there are lots of people involved. And even as of a week ago, there were big numbers. Now the numbers total are over 4,200 cases of Ebola in the current West Africa outbreak, with over 2,000 deaths, running right at around 50% death rate. Numbers here from a few days ago show cases and deaths in Guinea, Liberia, Sierra Leone, and then a few scattered cases, Nigeria with 21 cases, now 8 deaths, and Senegal with just 1 case and a survivor that didn't seem to spread. As some of you know, there's also currently an outbreak in the Democratic Republic of Congo with a different strain of Ebola, so seemingly unrelated to the West African outbreak going on now, but more and more cases being reported from the Democratic Republic of Congo as well. But what we see is it's centered around 3 places, started near the Guinea-Liberia border, growing from there and spreading through rural areas and then getting into capital cities and exploding with many more cases since then. So is Ebola a big deal? Yeah, over 4,000 people have been affected, over 2,000 people have died. Definitely this is a big deal for lots of people. But as some in the local teenage vernacular would say, is Ebola like totally the worst thing ever? And is this really that bad of a thing going on? And I think it's an important question because we need to keep Ebola in context. Yes, Ebola is terrible. Thousands of people have been infected, over 2,000 people have died. It's affecting families, it's affecting communities, and it's affecting countries, and it's affecting all of us. So Ebola definitely is a big thing and it's a bad thing. But we do need to put it in the context of the lives we're all living and other things going on in the world. Here on the slide on your screens, you can see a graph that looks at preschool deaths. So deaths in children aged less than 5 years per year. There are currently about 6.6 million preschoolers dying unnecessarily every year around the world. That comes down to about 18,000 preschoolers dying unnecessarily every day of every week of every year. There are lots of deaths. Almost half of them are newborn deaths from complications and infections. And then there are a variety of other conditions that we can see here in the fine print on your screens that account for other deaths. Between newborns and other preschoolers, about 18% of these deaths each year are from pneumonia. And if we do the math, that means that about 4,000 preschoolers die of pneumonia every day. So that means there are as many children, young children, dying every day of pneumonia in the world as there are people affected by Ebola during the past 6 months of this outbreak. So yes, Ebola is a big deal, but if we look statistically at what's going on with preventable deaths in the world, pneumonia and malaria and diarrhea and even meningitis are bigger deals in terms of numbers of people dying. And they're exponentially bigger in the sense that there are many people dying every day of these other conditions. They're not as newsworthy, but to the individuals and families involved, they're as painful. They're not as they're as fear-provoking as Ebola, perhaps. But I think we do need to keep Ebola in context. It's big, it's bad, it's terrible, and it's tragic, and yet we're accustomed to lots of other tragedies affecting lots of other people around the world in similar or even greater numbers. So we're supposed to have some questions to keep us going here. And I think there's this polling thing. Lance, you can help us vote on this. But the question is, which of the following has killed more people than Ebola in 2014? Malaria, diarrhea, pneumonia, meningitis, or all of the above? Having just seen those statistics, is there a way we can vote electronically?
All the participants, if you'll look at the emoticons there, you'll see the far right there. It says A, and then you can just choose A, B, C, D, or E, and submit your answer. Does everybody see that?
This is a really cool system for interacting, even though I don't have it figured out. I'm not seeing votes coming up. I see one vote for all of the above. All right, Jason, that makes it.
I don't see that on my screen.
You'll see it says under participants, then it says Samaritans First Lance, and then you'll see the emoticons, and there's a smiley face, there's a hand up, and then there's the last box. It has a selection of a letter.
Yes, I see that, and everybody has an E, it looks like, except me. Jim Loeffler.
All right, so everybody, including Jim, agrees that E is the right answer. So sad but true, despite the tragedy of Ebola, there are lots of other things that are more tragic even in terms of numbers of people that are involved. All right, we keep moving on and enjoy technology. Where did Ebola come from, people have asked me. We don't really know where it came from, but we know what we've learned about it over the years. The first report and identification of Ebola was in 1976, first in Zaire, what's now the Democratic Republic of Congo, and then later that same year in Sudan. A total of about 600 cases with over about 400 deaths during those outbreaks. I put in fine print on this slide my own personal experience from 1985 to 1991. I was in Zaire, now Democratic Republic of Congo, and did not see a case of Ebola, but I was back in Congo in 1995, but in a different part away from Kikwit where the 1995 Ebola outbreak had been. So we can see that Ebola came from the central part of Africa where it first got recognized in humans. Has been in several countries, Congo, Sudan, Uganda, Gabon, Ivory Coast, South Africa, and then Congo-Brazzaville, the Republic of Congo. So Ebola has shown up around there. This new 2014 outbreak in West Africa brings in a few other countries, as we mentioned and as we've talked about. So where's Ebola still coming from? Well, it comes from two places as far as we know. It comes from fruit bats that apparently are asymptomatic and just carry it. So people can get it when they've been handling bats or bushmeat, even dead bats, and being in contact with live or dead bats, then they can get secretions from the bats that carry the virus and get into themselves. But most cases, once the epidemic gets started, and what's going on now in West Africa, are what the WHO is calling H2H, human-to-human spread, with the transmission and sharing of bodily fluids between different people. So the human-to-human spread is where it's mostly coming from, even though the fruit bats serve as the initial reservoir. All right, so far, this is our quiz time. Ebola outbreaks have been reported in all of the following countries except Guinea, Mozambique, Uganda, Democratic Republic of Congo, and Gabon. This is to say, are we listening? One of those countries was not on the list. The emoticons are listing it up there, and we have a mix. This is good. So I see we have a few answers. I'll just go back a couple of slides to where we said we've seen it. There have been a few cases in several countries. And so now we will all remember that we are getting educated, and we know that, at least to my knowledge, Ebola has not shown up yet in Mozambique. I do not feel suspicious or have ideas that because I said Mozambique it will start having cases. They're superstitious, I guess. So the next question that came to me several months ago, early April this year, we got a question from somebody who was planning to come to the CMDA conference for missionary physicians and nurses in Greece. There was a physician-nurse couple working in Guinea, and they wrote and said, "We want to travel from Guinea to your meeting in Greece. Is that okay?" So this was my first personal involvement, though from a distance. Should we allow somebody from an Ebola-infected country to come to a meeting with 700 people that would soon after the meeting be returning to 70 different countries, and would that be a safe, wise thing to do? So that raised a question and some good discussions, and obviously the person asking the question knew about the situation, and that's why he wanted to share his thought process and come up with a more mutual answer from the conference organizers. So a question would be, how do we respond? There are lots of ways we could respond, and I don't think we'll take time for everybody to type in their answers, but I am looking if you all do type in answers as we're talking. But then the question would be, what should we have done and what did we do? It takes a little bit of background information to be able to figure this out. We realized that if this couple was going to be infected, it would have come from a fruit bat or from a human-to-human contact with somebody else that was infected. We know that the incubation period varies from 2 to 21 days, even though most people have a 6 to 10-day incubation period. The incubation period between contact and illness can be as short as 2 days, and it can be as long as 21 days. So what we advised the person was that they have no sick contact with a fruit bat or a sick person for 21 days prior to getting on the plane to going to Greece. And that sounded like a good, straightforward answer. It's not necessarily easy when a physician and nurse are working with sick patients all the time, but the advice to make sure they would not be transmitting germs would be to wait until they had no contact for the maximum possible time of incubation period. So we suggested no contact with a fruit bat or a sick person for 21 days prior to departing for the meeting. But that doesn't quite answer the question, because what really counts as a sick person? This is a tough question for this couple, but it's also a tough question when we talk about caring for people in Liberia and Guinea and Sierra Leone now. What counts as a sick person to trigger Ebola-type care for them? We could say, well, the initial symptoms of Ebola are usually fever, often with headaches and myalgias and malaise. So anybody with that counts as a sick person, which means everybody in Africa getting malaria today counts as an Ebola suspect patient. The other option would be to say, well, if they have a fever and they're dripping blood out of body places, then that would count as being a sick person. So this is a tough question. So it's easy enough for us to tell this person to have no contact with potential sources of infection for 21 days prior to coming. This brings in some knowledge and understanding, but it leaves the question of what really counts as a potential Ebola patient to trigger either change travel for the exposed person or to trigger care for them when they have Ebola. Certainly if they come in with a label on saying, I have Ebola because I have a high fever and I'm bleeding out of my mouth and my bottom, that's suspicious. But in the day before that, sometimes it's harder to identify what counts as suspicious. All right, the incubation period of Ebola, another question time here. Varies from 1 to 7 days, varies from 7 to 42 days, is usually 8 to 10 days, is usually 3 to 5 days, or is unknown. The point of these questions is to satisfy the CME people and to remind us about all the cool stuff we're learning. And so I'm seeing numbers that are split. Does anybody else want to vote so we can get what I'm calling the right answer into the majority so we can feel democratic? Oh, they just did it. Somebody switched. Okay. So I would agree that it's usually 8 to 10 days. It varies from 2 to 21 days for the incubation period. And it usually lasts about 6 or 8 up until 10 days. So roughly a week to a week and a half. That's important as we realize that we'll be seeing patients that have potentially had contact, and the timing of their contact can be relevant as we make decisions about isolation and about care for them. Thanks for participating in the quiz questions. So then I had a question a few weeks after that one about travel. This came from a hospital in Guinea that I had visited last December. And the question was, a man has arrived at our mission hospital with fever and bloody diarrhea. Now normally fever and bloody diarrhea we would call febrile dysentery. We would be thinking about bacterial enteritis like shigellosis, an infection by Shigella. But this was in Guinea during a known Ebola outbreak. So a man arrived at this hospital in rural Guinea with fever and bloody diarrhea. The hospital had no isolation rooms at the time and had limited supplies for isolation equipment, mask, gowns, and gloves. So the question they were wondering is, should they see the patient or send him elsewhere? Let's go back to our voting thing. I don't know, Lance, if we can do this since I hadn't put this in as a question, but let's say A is go ahead and see the patient as best you can. B is admit that you can't care for him without isolation, supplies, and space, and send him away. So how many want to say A, see him anyway, and how many want to say send him out? This is interesting. We have a mix. We also have technology working against it since we still have C answers here. So the majority here would say send him on. That's an answer that to me just doesn't feel right because it's turning down the opportunity to care for a sick person. On the other hand, it's a response that thinks better because it means what's really wise in the big picture. And in fact, that's what they decided there. They decided to refer this man to a regional hospital, but that was not the end of the situation. This was early on, and I think it was late April when this happened. They also used that as impetus to make sure they got enough gowns and masks and gloves, and that they developed an isolation management plan for how they would deal with more patients like that. So I will admit that that response didn't feel good to me, but I think it was the right thing to do. And by our split little votes there, I would say that most of us are thinking similarly with what they did. But this is a tough situation. I thought this was just a tough situation early in the outbreak when people were recognizing that they needed to upgrade their supplies. But now, as we know, this is becoming more of a situation and a problem late in the outbreak in Liberia, where supplies and staff and space have been totally exhausted. So this is still an issue, and do we take someone and risk others nearby, or do we try to get them to an effective place? And what do we do when there's not a safe place for isolation? These are tough questions, and obviously there aren't necessarily easy answers for this. And logistics do matter in terms of what's available. This is a photo that Lance gave me from northern Liberia, I believe. For those that haven't traveled as much, most of us in this conference have, but for those that haven't, this is kind of a normal setting. You don't see any plumbing or pipes coming in or out of these buildings. You don't see any electrical wires. You see a dry canal there with a sidewalk board going over it. So body secretions and sewage even might be running next to the streets, not far from people. And hygiene is going to be a challenge. This is a normal setting for much of Africa and for many of the rural places where Ebola is happening. The logistics of what's available for living, what's available for hygiene, and what's available for patient care really do make a difference. So we're not just talking about we need better science or we need better clinical care to take care of the Ebola outbreak. We're really talking about a logistical problem of sanitation and hygiene in communities that have not previously had access to that. Then we can play dress up. This is the expanded dress up more than even what we do in this country. And as an aside, I think back even to when I came back from Congo to be working in this country, I believed that washing hands was a good idea between patients. But those of us working in this country with patients realize that it's only in the last 10 years that we've used the term hand hygiene. We haven't been used to washing our hands quite as thoroughly or aggressively or consistently between patients. But here we have a picture from Liberia showing the multiple layers of clothes and gowns and then plastic wrap over the top with multiple protections for each part of the body with heavy boots. This is a great way to protect contamination and germs getting in, but it's also a logistical challenge to be able to have these supplies and equipment, to be able to maintain and store them, and to be able to make them available and use them. So here are slides of a drying place with the boots and the gloves and some of the other clothes hanging up to dry after being decontaminated so they can be used again. From Médecins Sans Frontières, again, goggles hanging up to dry after being decontaminated so they can be used again. Taking care of even a small outbreak of Ebola provides a great logistical challenge. Taking care of the current outbreak of Ebola is a huge logistical challenge with needs for lots of supplies and equipment as well as personnel and space to put patients. I have not seen a medical report about the new rapid diagnostic test, but I'm told there is now a rapid diagnostic test for Ebola where a drop or two of blood and a half hour of time is all it takes to determine if someone is Ebola positive. Lance or others on the call, do you know if that test is actually available in West Africa?
I can tell you, Phil, it's definitely not being utilized. The big, I think, concern that I've heard with it is that it doesn't have good sensitivity. There's a lot of false negatives. So right now, the only test that I'm aware that's being utilized is PCR.
Okay, so we do have a good test, but not readily available.
But
this picture here. Say that again, Lance.
I was just going to say, but if they could, develop that so that the false negatives were not so high, then it would have just a tremendous role in expediting the diagnosis in these Ebola treatment units. That's a huge logistical problem, Phil, is that some of these patients are sitting in these Ebola treatment units for 3 days waiting on an answer whether they have Ebola or not. And what breaks your heart is that in the suspect area of the Ebola treatment unit, you know that some of those patients don't have Ebola, and yet they're waiting on the test results, and they're sitting there hospitalized with many other patients that indeed do have it.
And that is indeed a huge challenge, because ideally everybody would have an individual isolation room. That's not practically feasible in these countries where there's a lot of Ebola now. So clusters or cohorts of patients make sense, but that means that those who are incompletely or wrongly classified are potentially exposed to other people. The picture on the screen there is the non-rapid diagnostic test that Lance and others were recently using in Liberia. That's a little canoe being paddled across the river that separates Guinea and Liberia, taking those white bags of blood samples from one country into the other where the testing for PCR for Ebola could be done. So we have diagnostic challenges, we have management challenges. There are lots of challenges we have, and logistics matter, and that's why we're involved in logistic ways as well as we try to deal with all this. So somebody else asked me the question, we treat other serious viral infections, why can't we treat Ebola? There are lots of viral infections that we now can treat, thanks to great medical advances in the last few decades. So why can't we treat Ebola? And of course, as we know, there have been changes in recent months, and treatment for Ebola is becoming more possible. But we must remember that supportive care works, at least sometimes. Lance tells me that the other man pictured with him in this photo was the first survivor, as we mentioned, of Ebola in Liberia with this outbreak, and supposedly recovered, at least in part, because he got early treatment and good treatment. Supportive care can matter. In a warm-up for this talk today, I gave a talk to our pediatric residents in Minnesota about Ebola last week and showed them some of these slides. And one of the questions they asked afterwards was, why do we even bother with all these other sorts of treatments? Why don't we just give everybody supportive care? If we could make sure everybody from the very beginning of their symptoms got appropriate hydration and nutrition and electrolyte management and blood products as needed, then even more would survive. One of my personal guesses is that the reason the Ebola mortality is down from 90% in some previous epidemics to only about 50% now is because of good supportive care. So early diagnosis and supportive care seem to be effective and helpful, but then we're back into those same logistical challenges. It's hard to give supportive care when supportive care requires isolation space, supportive care requires fluids that the patient might not be able to drink very well, would be helped by having electrolyte measurements and salt supplement sorts of solutions to give, and then giving of safe blood products. So supportive care should be emphasized rather than diminished as we continue to take care of Ebola. And then there are a few treatment options reported in the literature that aren't quite options yet until just recently for a few people. The first one, BCX4430, is an adenosine analog that alters RNA polymerase function so it can block the replication of Ebola virus. And that treatment in animal studies has been effective against Ebola in mice. It's also been tested against not Ebola but similar Marburg disease in monkeys and been found to be effective against Marburg disease in monkeys. So with more study, there's potential that this could be effective in monkeys against Ebola, which would then raise the question, since monkeys and humans share some similar features physically, that maybe it would also be useful not just for Marburg in monkeys, but maybe also for Ebola in humans. So there's work that needs to continue to see if that would be a good treatment option. Number two possibility I've listed is a different medication that also blocks viral replication. That medication has been shown to be effective at blocking the virus in cell culture, not necessarily safely for the rest of the cells around, but it's blocked it in cell culture, and it's been effective in the treatment of rodents. So again, something in the future to wonder if maybe this medication also might be able to be developed in the form and a dose that could be safe and effective for humans. So there's some potential. 3 months ago, we would have said that monoclonal antibodies were similarly in the distant future, and there are different monoclonal antibodies that interact with different parts of the Ebola virus that seem to be effective. The one that's hit the news and hit some important to us friends has been ZMapp. ZMapp is a combination of 3 different antibodies against different parts of the Ebola virus, and that has been effective in monkeys. Even recently, a paper came out suggesting that monkeys, even several days after illness started with Ebola, could be saved, not die. They could survive their Ebola with this medicine. So there's suggestion that that medicine could be more useful. I don't know exactly how much it's been used in humans, but news media tell us that 4 patients have received it. News media also says that only 2 of those 4 have survived. Kent Brantley and Nancy Whiteball, we've heard, have survived, and I believe those reports. I hear that the British guy who got Ebola in Sierra Leone, a British nurse, I saw in reputable-looking news reports that he had also received the ZMapp combination of 3 monoclonal antibodies. So that makes me think 3 of 4 survived, but I don't know the details of the other 1 or 2 that might have had this treatment. But at least there's this anecdotal and for some very personal and very happy experience to say that these antibodies are associated with this working. Some of us have followed the ethical concerns about using an untested, unproven medicine in susceptible humans. WHO has had meetings to talk about this and has certainly cleared experimental use of this medication in humans as ethical and appropriate, even though there aren't many doses to keep using. Franklin Graham wrote eloquently about this in an editorial in USA Today a couple of weeks ago. New England Journal of Medicine a few weeks ago was also supportive of expediting some of the usual research and ethical committee decisions to say it makes sense to go ahead and do this. But we still don't know if these saves, if this seemingly good effect of this medicine was just coincidental or because God answered prayer or because it actually did something to work. We're thrilled that people that got this medicine survived and are doing well, but we can't claim for sure that it was completely because of the medicine or that that's the only answer for what needs to happen. But certainly some excitement as we see what's going on and as we realize that this medicine has at least been associated with some good outcomes in some people that were not doing well before they received it. So, currently approved treatment.
Hey, yes. Bill? Oh, I'm sorry. Do you mind if I just make a comment about that?
I would love it if you would. You've been living up front with this.
Okay. Well, we as an organization, we do have anecdotal experience with ZMapp, and it is, let me preface my comments, it is anecdotal. It was 2 cases, specifically Kent Brantley and Nancy Wrightball. And I've intentionally waited for permission to make these comments, but we were responsible for administering ZMapp for these 2 patients, and again, they're just 2 patients. I think what you said is very true, that you have to have patients that have great supportive care. And when I say it was just an anecdotal experience, I know there's many more studies that need to be done. The organization that makes ZMapp is called MAP Biopharmaceuticals. They, in association with the developers like Gary Kobinger and Larry Zitlin and some other people, they have just come out with additional studies that show that very late in the course that the monkeys indeed have done exceedingly well. And I can just tell you from firsthand experience with Kent Brantley, it was a dramatic improvement in hours with administration. So again, that's just anecdotal experience, but he had a fever of about 104.8. He was breathing about 40 times per minute. He had the look, if you know what I mean. He was extremely septic in appearance. And within 2 hours after administration, he got up and he walked to the bathroom, and So clinically, he made it and just an incredible turnaround. So again, that's just anecdotal story, but it was very, very powerful.
And the power of the anecdote obviously has to be kept in context like you are. But as we look at other options, the WHO and others now are giving support to saying, anecdotal or not, let's go for it. So I think this is all very good. And those N of 1, anecdotal, one-patient studies are very important. And as we look at what happened, or what has happened in the last month and a half, I think we can see the world has made huge strides in the fight against Ebola. And some of it is based on these anecdotal cases, people that really matter to us. I wouldn't want to call Kent and Nancy anecdotes, but people that really matter to us, but their experience is part of what's moved the WHO and many others to be in support of carrying on and doing this. So Lance, thanks very much for that. What do you know about how available this medicine is soon to become?
It's I know they're manufacturing is the bottleneck issue, of course. From what I've been told is that MAP Biopharmaceuticals has reached out to other biopharmaceuticals, and they're going to try and get it to the forefront. We could talk about how it's manufactured, and it's incredible, it's miraculous, but it's a very arduous, time-consuming effort. So I don't know how successful, but I know they are making concerted efforts to make that happen.
Thanks for that. That's very helpful. Okay, so approved is not necessarily what we all do all the time, but for our quiz question, currently approved, meaning FDA, Food and Drug Administration, currently approved treatment for Ebola is limited to careful fluid management, judicious electrolyte management, use of blood and blood products, or all of the above. You can vote as we see what's going on there. This is beautiful. I can see the numbers and see people are thinking as they vote. And they saw A and B and liked them, and then they realized D was going to be all of the above. Very good. All of the above, all of those are true, all of those are effective, and that's all that's approved. So officially we have to say for CME purposes, ZMAP and other things aren't approved, but I think all of us would give hearty support to continuing to try those other sorts of things for future patients. So can't we prevent Ebola? What can we do? We can avoid bat contact. We can avoid direct contact with infected human bodies, whether dead or alive, meaning funeral habits need to change in some places as well as prevention. And there is some report, some of it in the last couple of weeks, coming out that vaccines have been successful in primates several months ago, and a report about a vaccine in rodents last month. I've heard anecdotal reports of another vaccine in monkeys being shown to be effective in a report from last month that I couldn't find medically. But vaccines look like they're coming along, making progress, and looks like this will be easier than HIV has been to prevent, because it looks like vaccines will have some success, but that's not available to us this year, even though it might be in upcoming years. So prevention of Ebola still comes down to appropriate contact, meaning protected contact with infected people, avoiding bats, and research can continue about vaccines. Are there other comments from anybody about vaccines? Have you heard of other things that I don't know about? All right, hearing no comments. There was a meeting last week, the 4th and 5th of September in Geneva, Switzerland, that reviewed a lot of this. I heard there were about 160 people representing several different countries as well as government and non-government organizations. So WHO hosted a conference as a consultation on potential Ebola therapies and vaccines. They talked about lots of these medicines and what might be able to be useful. And the only practical clinical idea that's come out from that conference that I've heard so far is that we should consider using antibodies from people who have survived Ebola. So using the serum from Ebola survivors to give to other people. Presumably when somebody survives Ebola, they've generated lots of different antibodies against different parts of the virus, and they still have those antibodies floating around in their systems for a while, potentially for a long time. So using serum from them, or if we have the resources, maybe even plasmapheresing off some of those immunoglobulins, could be useful to treat people with Ebola. So that's something that by news I hear Kent had that tried as well when he got blood from a 14-year-old who had previously been under his care and then survived Ebola. There's logic, and this consultation expert group in Geneva came through as that was their main recommendation, that serum from Ebola survivors be considered in the treatment of Ebola patients. And then they talked about all the other medicines and vaccines that we need to continue to develop. Lance, did you hear, or did anybody else hear more details coming out of that Geneva consultation?
No, we've heard just about what you just summarized very well.
Okay. All right, so we will keep working on that. And it's reaffirming to know that the things that were being tried in the past months even, that's all they can come up with so far to say to do.
Hey, Phil, I'm sorry I had to step out for a minute, but I can just elaborate on a couple. They're really pushing forward, like right now, I believe you talked about a pyrazine carboxamide inhibitor. There's one called, if I'm not mistaken, there's one that's come to the forefront. It's manufactured by Tecmera. It's called KM Ebola. I don't know the generic name, but that's being utilized for post-exposure treatment. There's also another vaccine that's now being made available for post-exposure treatment too. It's a vesicular stomatitis virus vaccine. Anyway, so that's another one that I'm aware of. There's also another one that uses an adenovirus as the vector for a vaccine, but they're pushing forward a lot of these drugs, or making them available for people. I know, like Emory, well, they utilized, in conjunction with our management of Kent and Nancy, they utilize ZMAP as well as ourselves, and they also have had available to them this TKM Ebola as well. So yeah, these are being utilized.
Thanks very much. Those are helpful comments. The slide I put back up here with that rodent vaccine at the bottom, apparently that was the VZV, vesicular stomatitis virus vaccine, associated one where they used that one there. So that's very helpful. Thanks, Lance. So studies continue. CME question number 5, the last one. Studies continue in regard to zinc in the prevention of Ebola, preventive Ebola immune globulin, mixtures of monoclonal antibodies, and HIV medications adapted for Ebola. Research continues in lots of things, but at least which of these things is the one we've talked about and mentioned having potential? The votes are coming in. All right, so we're all there. C is the mixture of monoclonal antibodies. That's ZMAP, and that's one where studies are continuing. I have not heard anything about zinc for prevention of Ebola. The immune globulin seems to be talked about in terms of treatment. I haven't heard yet of studies using it as prevention, though that should be coming. And Ebola is a bit different than HIV, so I'm not sure those medicines will be very helpful. But we'll keep anticipating more research coming from those things. So the question I'll bring is more inspiration as we get towards the end than just information. How would we pray if we were dying of Ebola? NBC was able to advertise a recent interview at the Samaritans Purse headquarters by flashing Kent Brantley talking about what he would pray and what he did pray. So as I understand it from news, others of you perhaps involved with personally, Kent's answer was that he would pray, "I want to be faithful to you." What a great prayer, what a great model for all of us. How would we pray if we were dying of Ebola? Maybe not just heal me, maybe we would have the godliness of Kent to be focused on being faithful. But I would say Kent can be the model for us to ask the question, what do we pray and what do we say even if we're living without Ebola? And will we be faithful to our own calling, and will we try to be faithful to God through whatever we're doing now? Indeed, there are challenges for us, and we should all be faithful even if we're not living in Liberia in the throes of an Ebola outbreak. Or as Rick was recorded in the newspapers and news media to say, before he was transported from Liberia to Nebraska. He said, "You don't need to necessarily transport me. I know that would be tough because," as he's quoted as saying, "Jesus is right here with me in Liberia." And indeed, for all of us suffering and working and doing whatever we are with the Ebola outbreak that's going on in West Africa now, the comfort of God's presence is important to us. When I finished that warm-up talk to this one last week with our pediatric residents in Rochester, afterwards one of the residents raised her hand to make a comment. And she mentioned that she had been in Liberia a couple of years ago as a medical student, and then she choked up and got tearful as she choked out the words, "And the 2 doctors who were my main mentors have since died of Ebola." Ebola is a challenge for all of us, but we can all take heart that Jesus closed the Great Commission by telling us that he would be with us always, even to the end of the age. So one of the challenges we have as individuals and even as institutions and organizations is how do we combine the comfort of with the "as you are going into the ends of the earth" first part of the Great Commission. And these are tough questions for us. I started by saying that I don't know much about Ebola from personal experience. I always wanted to see it, but then turned it down when I had a chance. I think we all have to be faithful to God. If any of us lacks wisdom, we should, as the Bible tells us, ask God, who will provide wisdom to us. I think back to the CMDA conference for physicians working overseas in Greece that we had in April and May of this year, and talking to someone there who was working and worshiping with an international church in the capital city of the country where he was, a congregation of less than 150 people, 19 of whom had died, most of them being killed within the previous decade. People are putting themselves in places of risk. We can think of the recent books, Insanity of God and Insanity of Obedience, that talk to us about Chinese believers and how they see going to prison as their seminary training. They're not ready for Christian ministry until they've been persecuted and gone to prison, is one of their ideas. So how much should we go for comfort and safety, and how much should we be willing to go out farther? I tend to fly on Delta Airlines when I fly, and I was thinking about it a couple of days ago as I was on the Delta flight, and a couple times around their safety video at the beginning, they made the statement, at Delta Airlines, our first priority is your safety. Now, I'm glad Delta wants to keep me safe, but if their first priority was safety, they would say, stay in the waiting area. Airplanes have risks. Just don't fly at all. In fact, I went to Delta not so they would make me safe, but so they would get me halfway across the country. Sometimes I think we can get so into our safety culture that we say our first priority in life is to be safe, and we might forget that transportation is really the main priority. And as we're thinking about the Great Commission, it's not, I'm with you always to comfort you and keep you safe and comfy. That's part of it. Jesus is with us always. He will keep us right with him, and there is great comfort in that. But somehow we need his wisdom to know when is it we should step into an Ebola outbreak, when is it we should stay away and do research and encourage and pray for people. These are challenges for us. And I'm reminded, too, that God gives us that wisdom, and he also gives us the encouragement of being part of a big family. As the Ebola outbreak was starting to swell and some of our friends were being newsworthy, I looked at our refrigerator in our kitchen. Like many of you, we have lots of pictures of different people as prayer reminders on our refrigerator. And already before they were famous, there was a prayer magnet up there that Amber Brantley had given to my wife in May this year at a conference together. And the reminder to us that we are all in this together. We can think about the Kents and the Ricks that many of us have known and worked with. We can think of other connections we have in the great family God's given us. One of my sons just graduated from Moody Bible Institute's aviation program and then realized afterwards, he says, oh, that guy does have the same last name. My flight instructor was one of Nancy Wright-Bowles' sons. We're all tangled up in this great family we call the church. And as members of this family, we can work together, we can pray for each other, and together, for ourselves and our groups, we can seek God's wisdom as we know how to advance. So I'm comforted even in the tragedy by seeing God at work and seeing God knit us together. I'm humbled as I realize we all need his guidance as we work through all this. And I am open to you all in the last few minutes because I'm expecting that you have some other thoughts and comments? I just noticed, Danita, now a comment from you. Thank you for that, even though you haven't joined with some of the audio parts of it. But I'm guessing some of you might have comments about the tangible medical, clinical, or public health or bigger implications of Ebola. So I'm open to all your comments as well. I was not expecting to leave us speechless there. It is great to be able to be part of God's big family as we deal with this.
Well, Phil, I'll just comment. This is Lance again. First of all, phenomenal presentation. That was very comprehensive and thought-provoking. There's so many, issues, just from a medical perspective, logistical perspective, ethical perspective, and spiritual perspective, and you did a very good job of presenting those. One thing I just wanted to comment on the last comment you made is, I think everybody has to look at this on an individual basis. God, in terms of the Great Commission, God has a unique calling for all of us, and for some of us, that is Liberia, and for some of us, it's in our backyard. That's between you and God. When we were there in Liberia, I can tell you that, and this sounds like just a Christian cliche, but literally, I said we could cut it with a knife. You could feel the power of prayer. It was so incredible. I mean, just in all of our decision making, we felt so blessed by thousands and thousands of people praying. But the reason why I'm just saying that is because, it's between you and God, how He calls you. But you can contribute, whether it's financially, whether it's, physically, in person, or whether it's prayerfully. But, just ask, that's a personal decision, but we can all contribute however God calls us. There's a lot of different callings for this cause.
And Phil, this is Tom. I'm the epidemiologist here at Samaritans Purse, and the opportunities to serve in the manners which Lance has just put forward are going to continue for a while. As you know from looking at any of the charts that are coming out, that this disease, particularly in Liberia, is in its exponential phase right now. We do not know, because we have not seen this disease in this kind of environment before, when that phase will peak over and begin to subside. But for now, it's in exponential phase. It's growing phenomenally, and the opportunities for all of that are abundant, and everybody, we need everybody that's listening in and those that have an interest to be involved.
Yeah. And Phil, just I'm going to throw out a ST advertisement. We did face a big blow with the infection of Kent Brantley and Nancy Wright-Ball, and honestly, it was traumatic to our organization. But God is faithful. We have come home. Our organization has been phenomenal at supporting us in the healing process. We are re-engaging. We are making plans to go back. Our approach is a bit different. Phil, the numbers are so daunting that the patient to caregiver ratio is just so massive that we are coming back with a home-based care plan where we're going to, by default, we are going to bring the care to the home, but we need tremendous support for that endeavor. So, I know there's a lot of people listening. Please be in prayer about that. We need a lot of volunteers. We need a lot of financial and prayerful support. So just wanted to
Lance, I
share
appreciate
that.
Okay, this is Ray Martin from...
Thank you.
This is Ray Martin from Christian Connections for International Health. Just an announcement. CCIH, some of you know CCIH. It's a very large network of Christian organizations and individuals working in global health from a Christian perspective. Samaritans Purse and SIM and some others on the call are members of CCIH. We're working on setting up some kind of framework to facilitate sharing of intelligence and information among our members who are responding to the crisis. Quite a few of our members are involved in one way or another, and we have probably 25 or so members in Liberia who are asking for information and help. So if you want to tap into this network that we're setting up, send an email to ccih@ccih.org, and we'll make sure that you're included.
Yeah, I personally appreciate Lance and Ray what you both said, because it's exciting to hear that there are new approaches as the epidemic seems to overwhelm. There are approaches to be modified and do that. So between Samaritans Purse and CCIH and others on the phone, I think that's exciting. I know some of the names I see listed. Mark just joined us. He's doing public health work. And indeed, God could use all of this to grow new things that are going to reach into communities in great ways to combat Ebola and spread the kingdom. So I think this is exciting. Thanks to each of you.
Well, I'd like to make a comment, I guess. You know, right now we're working with 2 hospitals, one in Sierra Leone and one in Liberia. And while we're not a treatment center for Ebola, one of the things we feel is so important is to be able to provide the medical services to those who don't have Ebola. And it's been really challenging. We have people coming to the hospital who don't want to identify themselves with Ebola, so then we deal with the exposure, so we have to worry about some of the same issues that Dr. Fisher referred to at the beginning of his presentation. What we're struggling with now, for instance, in Sierra Leone, is that we had one exposure, and therefore the government in tracking, they have now put the whole hospital in quarantine. So we have about 44 staff members who are locked up in the hospital with the military guarding the hospital, keep people from coming both in and out. And so now we're trying to wait through our quarantine period. We ended up losing, well, we had 3 staff members who ended up testing positive for Ebola. 2 died, 1 survived. And now we face the issue of what do we do about reopening, including how do the staff members actually feel. We have tried to gear up, provide greater quantity of supplies and more training to everyone involved, but it's a real challenge. As many of you know who are out there probably, that as Dr. Fisher actually made the point, more people are dying from other things than Ebola. And indeed, we're having multiple patients showing up on our doorstep, particularly during this quarantine period, who are seeking help and literally dying on our doorstep. And so I think there's a tremendous challenge, you know, as the healthcare system is basically broken down, not just in the treatment of Ebola, but everything else. And we're having a real crisis in both locations. Liberia, the same thing is happening, and we're struggling to try to take care of these kinds of issues. So I just wanted to put in a plug for treating all the other cases, and I believe huge ministry involved in that as well.
We saw the exact same thing, and it's heartbreaking because we corroborate with what you're saying. Is there's unfortunately many people that are going to die from non-Ebola related disease as a result of the collapse of the healthcare system.
I guess I'd only add that there's the individual choices to going out and serving, and sometimes there is the organizational administrative choices as to do we expose our hospitals? Do we make the choice to encourage them? And I think, you know, we have to recognize the importance of individual choice and God's calling in facing those situations. But indeed, there is the administrative choice of do we put people in harm's way. But I think, you know, we cannot neglect the fact that I believe we are engaged in a real controversy with the devil in this. He is trying to fill those nations with fear and draw them away from God and go back to their traditional religions. And, you know, science itself is not the answer. It has to be a faith answer. So I support the work that you have done and the encouragement you've given in this presentation as well. I think it's extremely important. Thank you.